Very good afternoon, students. This is Dr. Khushbu Mahajan, your dermatology faculty, and today we will be discussing the last 5 years questions of dermatology. And sorry. So today we'll be discussing last 5 years of questions which were there in your FMGE exam, and the purpose is I'm sure you're all set for your exam. So this is just going to be a quick revision for all the topics that you have covered, because we all know that last 5 years question based topics are the most important for us. So we will quickly go through these questions here, and before I forget, I would like to say please like and subscribe to this channel so that you get future updates. So beginning with the first question here. A 50-year-old female, before I begin, if there are any queries, you are free to post your queries in the chat box, whether related to question or even if you have any other doubt, I'm here to clear it out for you. So just post it in the chat box. So the first question, a 50-year-old female patient, a known case of ovarian cancer, presents with difficulty in activities like climbing stairs, getting up from chair, combing hair, etc. And there is an image given, and you've been given that there is a characteristic sign found on examination. So what is the most probable diagnosis? So very good, all of you. Dr. Swati, Pradeep, Brinda, Isha, Dr. Priyanka, you're all right. The answer is dermatomyositis. What is the sign which has been given here? What is the sign that they have given? So obviously from the question you know that we are talking about proximal muscle weakness. So proximal muscle weakness with this characteristic sign which is called as, I'm still waiting for your answers. Very good, doc. Everyone. So this is, yes, this is heliotrope rash. I'm sorry I don't have your name, just an S. So heliotrope rash, or this confluent macular violaceous erythema seen on the upper eyelids, is called as heliotrope rash, and heliotrope rash is a characteristic feature of dermatomyositis. So dermatomyositis, as the name suggests, has skin involvement and muscle involvement. Muscle involvement is in the form of proximal muscle weakness, and skin involvement, the most common features are Gottron's papules, Gottron signs, and then this is characteristic rash on the upper eyelid called as heliotrope rash, right? So amazing. Since you know all about it, I'll move on. Is there anything in the other options that you want me to discuss? So quickly, SLE will have malar rash. Systemic sclerosis will have bound down skin. Cushing syndrome will have telangiectasias, buffalo hump, obesity, and you all know that all steroid related side effects. So moving on to the next question. An 18-year-old female patient comes with the following findings. Which of the following is pathognomic of the primary stage of this disease? So which is pathognomic? So here in the options I have various primary lesions: papule, pustule, abscess and comedone. So what do I see here? I'll wait for your answers again. Amazing. So you guys know everything. So yes, the answer is comedone, and Swati, Priyanka, Gajnan, Pradeep, Vipin, Gosal, Prakul, Alok, Brinda, you all are right. So yes, so what we see here are whiteheads or comedone. So in the image itself, I know that I am seeing acne, and it is an 18-year-old female, the right age where you see a lot of acne, and you see acne on the forehead. So the image is of acne, and we all know that comedone is a special skin lesion. It is a special type of skin lesion which is pathognomic of acne vulgaris. What is comedone? Comedone is a blocked pilosebaceous duct, and comedone can be both open and closed. Open comedone is called as whitehead, and closed comedone is called as blackhead, right? So you all are right. Comedone is the answer here. So next question. A 26-year-old male presented with erythematous plaques covered with silvery scales over the extensor surfaces of both arms. Punctate pitting was noted on examining the nails. What is the most likely diagnosis? Amazing, you all know the answer. Yes, it is psoriasis for sure because there are enough hints in the question. We have erythematous plaques, silvery white scale is characteristic of psoriasis. Then we know that psoriasis, the most common form of psoriasis, involves predominantly the extensors. And then in nail, what do I see? I see pitting. And pitting is the most common feature of psoriatic nail, right? And here, even if I look at the image, there is an erythematous plaque with silvery scales. Lichen planus, on the other hand, will present with 5 P's: purple, pruritic, polygonal, papules and plaques. Eczema will not have silvery white scales. Pityriasis rosea. Okay, I want answer here. What kind of scale do you see in pityriasis rosea? What is the characteristic scaling that you see in pityriasis rosea? I'll wait for your answers. I'm sure you know it. Yes, it is Christmas tree pattern. Christmas tree pattern is the arrangement of lesions that you see in pityriasis rosea. Absolutely right. Herald patch is the first lesion that you see. Okay, the type of scale is called as collarette of scales. Collarette of scales, so, or a collar of scales, because when you have an herald patch, in herald patch, if you look at the inner border, there is a collar of scales. This is called as collarette of scales and is typical of pityriasis rosea. Okay, yes, collarette of scales. The branny scaling which some of you are telling me is characteristic of pityriasis versicolor. So don't get confused. Branny scales or powdery scales is a feature of pityriasis versicolor, right? So moving on to the next question. A patient presented with itchy lesions as shown below. What is the diagnosis? So though the image is not very clear, but if we look at the options, I'm sure you will be able to tell me what is the correct answer here. So when itchy is an option, I think we should obviously rule out psoriasis and warts because both of them are not itchy. So what will be the answer here? Absolutely right. It is lichen planus because, as I just mentioned, you are seeing purple, papules and plaques which are plain topped and which are pruritic. As is mentioned in the question, the lesions are itchy or pruritic. So 5 P's, which is seen with lichen planus. Right? In scabies, if they have to give you an image, they will give you an interweb space on an area like that. And what is the characteristic lesion that I see in scabies? Which is the special skin lesion that I see in scabies? What is the characteristic skin lesion of scabies? Absolutely right. Burrow is the characteristic skin lesion. It is the track that is laid down by the female knight. Dr. Sakshi, circle of Hebra is the characteristic distribution. The lesions that you see in scabies patients form an imaginary circle on the body, which is called a circle of Hebra. So circle of Hebra tells me about the distribution of lesions, whereas burrow is the characteristic lesion that you see in a patient of scabies. Wonderful, amazing. So moving on to the next question. A patient presented with multiple painful blisters on an erythematous base along a dermatome. So again, everything is mentioned in the question. Multiple painful blisters along a dermatome. So what is the diagnosis? Which skin condition presents along a dermatome with multiple painful blisters? Amazing. You all know everything. You don't need this session. So it is herpes zoster. Absolutely right. So herpes zoster is a viral infection caused by varicella zoster virus, and it is not a direct infection, it is reactivation of a latent virus. So it is reactivation of a latent virus, and this reactivation occurs along a dermatome. So along a dermatome, patient develops painful blisters. Patient develops painful blisters along a dermatome, right? Herpes simplex, on the other hand, will present with coalescing vesicles. Molluscum contagiosum will present with umbilicated papules, and chicken pox will present with, what is the typical appearance that you see in chicken pox? Tell me. The characteristic appearance of in a chicken pox patient, again a potential question, and that's why I'm asking you this. Yes, you are right, Ranjit. You give acyclovir 800 milligram 5 times a day in a patient of herpes zoster. Absolutely right. Yes. So, Sakshi, you're right. You have polymorphic lesion, and the characteristic lesion is called as dewdrop on rose petal appearance. So, dewdrop on rose petal appearance is characteristic of chicken pox, because this is also a potential question. So, absolutely right. Polymorphic rash, which is centripetal in distribution, and dewdrop in rose petal appearance. A 45-year-old truck driver. So again, I'll mark the important points, and that is what you should do in your exam also. Truck driver with history of multiple sex partners. So I know I'm dealing with an STI here. Presented to the dermatology department with the condition shown below. Then what is the most likely diagnosis? So the question is telling me it is an STI, and in the image I am seeing palms where I am seeing some hyperpigmented papules which are there on the palms. There is a sign also associated with this. Can you tell me this? You all are right. The answer is secondary syphilis here. Secondary syphilis is an STI. Secondary syphilis presents with a diffuse rash on the body, and characteristically I have rash which is present on my palms and soles, and there is a sign which, absolutely right, Sakshi, it's called as Buschke-Ollendorff sign. If you take the blunt end of the pin and press these lesions like this, the patient winces in pain. So this is a characteristic sign which we do on palms and soles. So presence of these lesions on palms and soles with history of STI, multiple sex partners, is very, very characteristic of secondary syphilis. You should not be confusing it with any of the given options. One, they are not an STI, and second, they do not present like this. Amazing. So, a 50-year-old smoker presents to the hospital with a painless oral lesion. I have a painless oral lesion. A patient is a smoker, 50-year-old, and white patch that develops in the oral cavity. What is the diagnosis here? So there is a asymptomatic white patch in a smoker. What will be the diagnosis? Absolutely right, and I'm so glad that none of you are confused here. Yes, the option A or leukoplakia is correct. Leukoplakia is a pre-malignant condition. It is a condition which is seen in smokers. It presents with painless asymptomatic whitish patch. So what do you do if you see a patient of leukoplakia? You observe the patient and you go for a biopsy to find out what exactly it is. Okay? Why can't it be candidiasis? Candidiasis, lichen planus, both of them will be symptomatic. They will not be painless. Can it be oral cancer? Yes, it can be oral cancer. But oral cancer is a very, very diffuse term. It may, when I biopsy a leukoplakia patient, it may come out to be oral cancer. But just at looking at it, you do not say, unless you have a fungating painless mass which you see in the oral cavity. A whitish patch in a smoker would always be leukoplakia. And yes, you are absolutely right. We need to do a biopsy to rule out oral cancer here. So just with this history and this picture, you cannot say that this is a patient of oral cancer. Clear? Very good. You guys know very well. I'm so glad to see that. Right. Which of the following is the causative agent for acne fulminans? Which is the causative agent for acne fulminans? There are a lot of bacteria which are given here. Don't get confused. The answer is very simple, which we have read a lot of times. It is Propionibacterium acnes, also called as Propionibacterium. So any number of names given, it does not matter to us, because we know that Propionibacterium acnes is the causative agent for acne fulminans. The other bacteria which can also cause is Staph epidermidis. Just to tell you, but don't get confused, Propionibacterium will only be given to you. Right? Easy question again. Now, a 30-year-old pregnant female presents to the dermatology OPD with the given condition. What is the likely diagnosis? So, I have a pregnant female who's presenting to me with this image where I am seeing hyperpigmented macules which are present on the cheeks, on the chin, on the nose, on the upper lip. Again, a very, very classical. Absolutely right, all of you. Yes, this is melasma, which is a type of facial melanosis. Okay, what is melasma in pregnancy called as? When patients have melasma during pregnancy, what do I call it? There's a special name for it. So there you will get the answer. Yes. So why did none of you say cloasma as the answer here? So here again, this was to confuse you. A lot of you said melasma because we didn't even look at option D. So if there is a pregnant female who is presenting with pigmentation and in the option cloasma is also given, please don't mark melasma. Please mark cloasma as the option. So when we look at questions like this, the only idea of giving you cloasma here was, I knew that most of you would answer melasma because that is what we look. We look at the second option. We don't even look at third and fourth option. Right? So don't get confused in exam. Though you may be knowing the question well, please read all the four options. Please do read all the four options. So here the answer is cloasma. Right? Cloasma is the melasma that you see in pregnancy. Okay, look at the other options. SLE presents with malar rash, butterfly rash. Rosacea, on the other hand, presents with telangiectasias and redness. Here I am seeing pigmentation, and here the answer would be cloasma. I hope yes, absolutely. So I hope you all are clear now and you will read all the options in the questions when they come. Next question. Koebner's phenomena is seen in all of the following except. In which condition do you do not see Koebner's phenomena? So what is Koebner's phenomena? Koebner's phenomena is development of lesions of similar morphology along the lines of trauma. So whenever there is a trauma, so let me look at it. Yes, you all are right. The answer here would be herpes because we all know that these three are the most common conditions where we see Koebner's phenomena. So I'll just revise Koebner's phenomena. And okay, before we end, I would want you to tell me, where do we see pseudo-Koebner's phenomena? Where do we see pseudo-Koebner's phenomena? So Koebner's phenomena, also called as isomorphic phenomena, very good Vihari, is that in a patient of vitiligo, if a patient scratches or gets hurt along the lines of trauma, you see development of vitiligo lesions, and similar thing is seen with psoriasis patients and lichen planus patients. This is Koebner's phenomena or true Koebner's phenomena. Then there is something called a pseudo Koebner's phenomena, which is seen with, absolutely right, Vipin, and some names which I'm not able to say because they are more of initials. So yes, molluscum contagiosum and Watts are the reason for pseudo Koebner's phenomena, and it is pseudo Koebner's. Why? Because here it is, the phenomena is occurring because of seeding or auto-inoculation of organisms. So molluscum contagiosum and warts are the two most common causes of pseudocobner's phenomena. Absolutely right. Okay, identify the type of psoriasis in the given picture. So we know that there are various types of psoriasis and we should be broadly knowing about their clinical features. So which is this type of psoriasis? So here there is some confusion between B and A. This is guttate psoriasis. This is not erythrodermic psoriasis. Why? Because you're seeing small, less scaly plaques on the trunk. I know it may be a bit confusing. Erythrodermic would be there will be diffuse redness and scaling which will be given to you. So erythrodermic is when erythema and scaling involves more than 90% of the body surface area. So there in the image you will not see so many left out areas. You will see a generalized redness, a generalized scaling. Here what you are seeing is crops of small reddish papules and plaques, but the plaques are typically smaller than what you see in psoriasis and they are less scaly and they are present on trunk. So here the answer is guttate psoriasis. There should be a history of upper respiratory tract infection, I agree, and if that is given to you it will become more suggestive, but even if this image is given to you, you should be able to make out. See, it is not pustular psoriasis. You are not seeing any visible lakes of pus. It is not inverse psoriasis. What is inverse psoriasis? It is flexural psoriasis. I told you psoriasis most commonly involve extensors. So, inverse psoriasis is what will involve the flexures. Now, you are getting confused between erythrodermic and guttate. Remember, if they want to give you erythrodermic, they will give you full redness and scaling. They will not give you so many spared areas. Right? So, guttate psoriasis, again, important features. You're right, upper respiratory tract infection seen in children, seen on trunk, raindrop like lesions, less scaly, smaller in size. And how do you treat them? The treatment is also different. So, what do you give for guttate psoriasis? What is the treatment for guttate psoriasis? No steroids, no methotrexate. The treatment for guttate psoriasis is antibiotics. You give antibiotics because guttate psoriasis is thought to be caused by streptococcal throat infection. So this is one psoriasis which is not treated by methotrexate, and no dapsone, no retinoids. This is a type of psoriasis which is related to upper respiratory throat infection, so related to streptococcal infection, and so antibiotics are given for its treatment. Okay, some of you mentioned steroids. Tell me what type of psoriasis you use steroids. There is only one type of psoriasis where you use oral steroid. Otherwise, you never give steroids in psoriasis. What is that? Methotrexate is in general the drug of choice for psoriasis. So I'll quickly revise with you. So drug of choice is methotrexate, especially in cases of arthritis, in erythrodermic psoriasis, and in plaque type psoriasis. Then acitretin is used when you have psoriasis with HIV. In HIV positive patients, you use acitretin. And yes, in pustular psoriasis also you use acitretin. Where do we use steroids in psoriasis? We use it in pustular psoriasis of pregnancy. Not all types of pustular psoriasis. Only pustular psoriasis of pregnancy, which is called as impetigo herpetiformis. Alright? No dapsone. You don't use dapsone in psoriasis. You don't use dapsone in psoriasis. Are you clear? If you have psoriatic arthritis, you will prefer methotrexate. If still there is a confusion, please ask me here. But this is broadly what you use in various forms of psoriasis. Okay? So don't get confused. And guttate psoriasis, antibiotics. Clear? So we'll move on to the next question. What is used to diagnose the condition given in the below image? So what is the condition that we see here, and what do we use to diagnose it? Yes, you use Wood's lamp. So what is this condition shown here? You're seeing hypopigmented macules which are coalescing on the inframammary area. So what is this condition? And apart from Wood's lamp, so yes, you're all right. This is pityriasis versicolor. Okay, tell me one other test that you can do for pityriasis versicolor and what is the characteristic finding there? So P versicolor is caused by Malassezia, you are right, which is a fungus, and we do not do culture or gram stain or patch test for it. We do Wood's lamp examination, which because it fluoresces under Wood's lamp. But what is the other test that I can do? We can do a KOH mount. Perfect. What do you see on KOH mount in pityriasis versicolor? What do you see on KOH mount? Spaghetti and meatball appearance. Absolutely right, Shahmeet. Spaghetti and meatball appearance. You all know Ranjit. Right, Shifali, you're right. Dr. Swati, you're right. So spaghetti and meatball appearance or banana and grapes appearance is typical of pityriasis versicolor. Important things, yes, it presents with briny scales. You do a Wood's lamp. It presents with hypopigmented lesions. It can also present with hypopigmented lesions. The causative agent is Malassezia. This condition tends to recur and is usually seen in upper parts of the body. Very nice. So we quickly revise pityriasis versicolor. Moving on to the next question. A 26-year-old male presented with a skin lesion as shown below. Okay. Biopsy shows presence of multiple neutrophilic foci. What is the most likely diagnosis? So see, the questions are repeated with a little difference. I'm sure you know about it. We all know that yes, we've just seen an image which is similar to this. So we have a plaque which has silvery white scales present. So this is psoriasis, and a very important hint given to you is a biopsy where you are seeing multiple neutrophilic foci. What are these neutrophilic foci called as? Oh, you answered before I asked. Desingo, Pradeep, you're right. We call these foci as Monro's microabscesses. This is collection of neutrophils in the stratum corneum called as Monro's microabscesses. Quickly tell me, what are the other important histopathological features of psoriasis? Very, very important histopath feature of psoriasis. Monro's microabscesses is one. What else? What else? Dr. Rahul, absolutely right. It is parakeratosis or retention of nuclei in the stratum corneum. And Shah and Priya, you're also right. Kogoke spongiform pustules. This is also collection of neutrophils, but it is seen in stratum malpighi. So Monro's microabscesses is in the stratum corneum and Kogoke spongiform pustules is in stratum malpighi. And parakeratosis or retention of nuclei is a very very classical histopath feature that you see in psoriasis. Yes, you can see hyperkeratosis. Yes, you see elongated rete ridges which are club shaped called as camel foot appearance also. But these three are the most important features that you should be knowing at this stage. Wonderful. You guys are very well read and I'm so happy to see this. Next question. A 22-year-old college student presents with small depigmented lesions which have been there for 2 years now. What is the most likely diagnosis? Obviously, we have just studied about melasma, so you know it's not melasma. We've studied about psoriasis, so you know it's not psoriasis. So there is no rocket science here. You know depigmented lesions which are bilaterally symmetrical. This is vitiligo. Also, I can call it vitiligo vulgaris. Vitiligo vulgaris. Right. So here, is there any confusion? So vitiligo has lot of types. If you ask me what type is this is vitiligo vulgaris. You can also be given a segmental image where there is segmental vitiligo. Then vitiligo is an autoimmune condition where is this destruction of melanocytes and you see depigmented lesions, right? Very good. So this is vitiligo vulgaris. Coming to the next question, which is somehow I feel favorite with the examiners. It's there in NEET PG, it's there in FMGE. Painless lesions over vulvar area as shown is suggestive of. What is this suggestive of? So you see painless lesions and you see that they are raised. So you see painless skin colored two hyperpigmented papules which are there in the genital area. Okay, yes, so you are all right. This is condyloma acuminata. Condyloma means broad-based and acuminata means pointed. These are nothing but genital warts. So genital warts are also called as condyloma acuminata and they will typically present with painless lesions in the genital area like this. Genital herpes on the other hand would always be painful and will present with polycyclic erosions. Gonococcal vulvovaginitis will present with discharge. There is no ulcer, there are no lesions. What is condyloma lata? Tell me, what is condyloma lata? Yes, you all are right. For genital warts, the cause is HPV 6 and 11 and there can be other strains also 16, 18, 32, 33. 6 and 11 is responsible for low risk and 16, 18 are associated with high risk HPV. Okay, now I want to know what is condyloma lata because I saw one of you writing this as condyloma lata. Yes, condyloma lata is a manifestation of secondary syphilis and it presents with eroded papules. So you see erosions and these erosions have a discharge coming out which is teeming with spirochetes. So condyloma lata is a very, very infective condition. It is usually broad based and you see very fleshy kind of appearance there. Okay, yes, so genital lesion in secondary syphilis is condyloma lata. This is also painless. Remember, condyloma lata is also painless, but the clinical picture is different than this, right? Moving on, a farmer presents with a swollen foot and multiple sinuses as shown in the below image. What is the most likely diagnosis? Very good, amazing. Yes, mycetoma is the diagnosis here. Mycetoma is a type of subcutaneous mycosis or a deep fungal infection. There are three types of subcutaneous mycosis that you should be knowing about: chromoblastomycosis, mycetoma, and sporotrichosis. So mycetoma presents mainly on the foot. There is a swollen foot with multiple sinuses, with tumefaction. And what comes out of this sinuses? What comes out of this sinuses? Yes, it's called as Madura foot, Madura mycosis, Bihari foot. You're all right. What comes out of the sinuses? What is it called? Through these sinuses, I have some discharging things. What is discharging? Granules called as grains. So there are grains or granules which comes out of these sinuses and these are nothing but fungal colonies. These grains or granules are fungal colonies which are coming out of these sinuses. Presents with painless swelling. Very, very common in farmers. Mycetoma can be caused by fungus when it is called as eumycetoma, or it can also be caused by bacteria when it is called as actinomycetoma. What is the characteristic presentation of sporotrichosis? How does sporotrichosis present? Porotrichosis also has a characteristic presentation. So tell me, what is that? Yes, Deshingu, the treatment here is surgical management. Come on, how does porotrichosis present? Yes, it is caused by rose prick, Pratyuma, you're right. And yes, Dr. Sakshi and Priya, it presents with lymphatic spread. I am asking you this because the lot of time gives you question on sporotrichosis. A farmer, usually they will give you an arm or something and they will give you a linear lesion. So they'll give you a linear lesion. So you will have multiple papules or nodules which are present in a linear distribution called as porotrichoid or lymphangitic spread, because porotrichosis typically spreads by lymphatics, and so you have these linear lymphatic or sporotrichoid spread. You're absolutely right. It is also called as rose gardener's disease and is caused by prick by a rose thorn. Right? Amazing. Very good. Next question. A 35-year-old man has come with complaint of hair loss, and you see this. So what is the most likely diagnosis here? So difference between chroma and mycetoma. Okay, so chromoblastomycosis, you see copper benny bodies and you see more of a pigmented verrucous lesions. In chromoblastomycosis, you will be given a verrucous lesions which is pigmented, and you see sclerotic or copper penny bodies. Chromo means color, so the plaque is also colored, and when you see it under KOH mount, you also see colored or copper penny bodies. Yes, you're all right about this. So this is alopecia areata. So when you see this patchy hair loss, very smooth patchy hair loss. So again, I'll quickly revise with you. A patchy hair loss can also be due to tinea capitis. But in tinea capitis, either you will see scaling or you will see black dots. Chirion will present with boggy swelling, boggy tender swelling. When you see a patch like this, which is very smooth, and there is patchy loss of hair, you will always mark alopecia areata, which is an autoimmune disorder leading to patchy hair loss. Androgenetic alopecia, on the other hand, has patterned hair loss. So frontotemporal recession in males and the widening of central parting in females. So this is alopecia areata, and most of you have already mentioned what is the sign which is associated with it. It is called as exclamation hair sign, which is seen on the periphery of the patch, so which is characteristic of alopecia areata. Yes, you're right. Chirion presents with painful boggy swelling. Yes, Pradeep, the treatment will be intralesional triamcinolone or intralesional Kinacort. Whenever you see patchy hair loss, rule out tinea capitis, rule out alopecia areata, and rule out moth-eaten alopecia that you see in syphilis. Moth-eaten alopecia of syphilis is never the only presentation. There will be other signs of secondary syphilis which are associated with it. Very good. Next question. A 30-year-old female presents with lacy lesions in the oral cavity and genital, and her proximal nail fold has extended into the nail bed. So what is this sign? What is this sign called as, and what is this condition? Lacy lesions in the oral cavity, that means reticular pattern in the oral cavity, and proximal nail fold extending to the nail bed. You are all right. Yes, the answer here is lichen planus, because lichen planus presents with reticular pattern of oral mucosal involvement. And I'm asking you, what is this sign called as? Extension of proximal nail fold into the nail bed. Pterygium, Dr. Sakshi, absolutely right. This is called as pterygium, and it is the extension of nail fold. Pterygium is characteristic feature of nail lichen planus. The most common feature of nail lichen planus is longitudinal ridging, but the characteristic feature is pterygium. And lichen planus can affect my oral mucosa. There are various manifestations. The most common is oral reticular pattern, and this is symptomatic. And what is the symptom? Patient will give you history that the patient has difficulty in eating hot spicy food. Okay, so quickly I'll revise here. What is the characteristic feature of PRP? PRP will present with islands of sparing. We already have discussed psoriasis and pityriasis rosea, so I'm not doing that. So it present with islands of sparing. So you see sheets of erythema and you see islands of sparing, and you see PRP sandal or hyperkeratosis of palms and sole, and you see nutmeg crater papules. So all these three things are features of PRP. Okay, Wickham's triash is seen in lichen planus, but it is what? It is hypergranulosis. You put a mineral oil on a plaque of lichen planus and you see these whitish lines. These are called as Wickham's triash. Sometimes, yes, you can see it in the oral mucosa also. Right? Okay. Oh, next question is related to this. Which of the following features are not associated with the condition shown in the image below? We have already seen this image and we have discussed that this is lichen planus. So now it's very easy for you to tell me which is not a feature, because that also we have discussed. Yes, so we've already discussed that Monroe's microabscesses is a feature of psoriasis, and we already discussed that Wickham's striae is a feature of lichen planus. So in lichen planus, the characteristic histopath features are hyperkeratosis, acanthosis, and colloid bodies or apoptotic bodies. So these are apoptotic keratinocytes which we see. These are called as colloid bodies. And another important feature of lichen planus is hypergranulosis. In psoriasis, you see absence of granular layer. Whereas in lichen planus, you see hypergranulosis or increased granular layer. Okay. So these are some of the features that you see in lichen planus. So psoriasis and lichen planus is very, very important for you. What kind of alopecia do I see with lichen planus? So lichen planus can affect my skin, my mucosa, my hair, my nail, everything. In hair, what kind of alopecia does lichen planus lead to? Yes, Pradeep, it leads to scarring or cicatricial alopecia. So lichen planus and DLE are two most important causes of scarring or cicatricial alopecia. Right? Moving on. Which of the following side effects are seen most commonly with isotretinoin? So we all know that isotretinoin is teratogenic and so should not be given in a patient who's planning to conceive. However, if that patient takes it, we go for abortions. Why? Because it causes fetal side effects. So what are these fetal side effects? The most common, yes, you're right, is neural tube defect. So it leads to neural tube defect, and that is why we counsel the patient and we tell them that the child may have NTD, and so the patient may opt for abortion. So isotretinoin is highly teratogenic, right? So you should be just knowing about it. What are the other common side effects of isotretinoin? The most common side effect of isotretinoin is it causes extreme dryness, it causes cheilitis, it can lead to hypertriglyceridemia. The most severe side effect is it can lead to skeletal abnormalities, right? So you should be counseling the patient before giving. But the most important thing is it is teratogenic, so should not be given in patients who are planning to conceive. You can give it to reproductive age group along with contraception, right? Next question. A patient present with lesions as shown in the image below and later developed arthritis. What is the treatment of choice in a patient who presented with the following features? So we have already discussed So in a patient of, this is a patient of psoriasis with arthritis, so my treatment of choice, as I have already told you, will be methotrexate. Remember, steroids I told you is only given in pustular psoriasis of pregnancy. Puva and infliximab are used for the treatment of psoriasis, but they are not my first choice. My first choice will be methotrexate. Infliximab is a class of biological which is now very commonly used in psoriasis, right? But my treatment of choice will remain methotrexate, right? Moving to the next question. A 7-year-old intellectually disabled boy was brought with large warty crusts on the trunk, hands, and feet. Severe fissuring and scaling on the skin were present over the soles. What is the possible diagnosis? So, here by looking at the options, you know we are dealing with scabies. So, that's not a problem, even if you get confused based on the image and the question. But now the examiner wants to know what is this type of scabies. Yes, this is Norwegian scabies, or also called as crusted scabies. This is the most severe form of scabies, and I see it in individuals who are mentally disabled. Now, why is that? Because these children, they do not have itch response, so they do not itch. Because they do not itch, their burrows just keep staying like that, and that leads to formation of crust and warty lesions, right? So this is Norwegian or crusted scabies, very commonly seen in institutions where there are leprosy patients, in patients with Down syndrome. It is the most severe form of scabies, very, very infective. There are millions of mites. Normally, a normal patient of scabies has 10 to 12 mites, but crusted scabies patient has millions of mites, so it's very, very infective. Then animal scabies, the difference between animal scabies and human scabies is there are no burrows in animal scabies. Nodular scabies can be seen in genital area and axilla, and this represent a hypersensitivity reaction to constant itching to Sarcoptes scabi mite. What is the treatment of choice for scabies? How do you treat scabies? What is my treatment of choice? So the treatment of choice for scabies is, so what is the treatment of choice for scabies? 5% permethrin, absolutely right. So remember, permethrin is available as 1% and 5%. Remember, for scabies you use 5%, for pediculosis you use 1% permethrin. Okay, so remember this. Next question. Auspitz sign is seen in. So I'm trying to quickly cover as much questions as possible in this session, and I'm liking that you guys are very well aware, and I'm so happy to see this. So Auspitz sign is seen in, you are all right, psoriasis vulgaris, and we already, there was a question in which it said pinpoint pitting. So pinpoint bleeding point is Auspitz sign. So when you take a lesion of psoriasis, you take a glass slide and you start scraping. So initially you see increased scaling or accentuation of scaling, which is called as Grattage test. If you keep scraping further and further, in the end you see these pinpoint bleeding points which represent dilatation of blood vessels, and this is seen in psoriasis vulgaris. We do not commonly see it with pustular psoriasis. What is the sign that I see in pemphigus vulgaris? What is the sign that I see in pemphigus vulgaris? Yes, we see Nikolsky sign. Nikolsky sign is seen in pemphigus vulgaris. And Nikolsky sign is, if you apply a tangential pressure, that area of skin either forms a bulla or a raw area, commonly seen in pemphigus vulgaris, not seen in bullous pemphigoid. And yes, you're right, row of tombstone is a histopathological feature that you see in pemphigus. right? But the sign, if I ask you, will be Nikolsky's sign. Row of tombstone is seen on histopathology, right? Okay, next question. A young man presents with a leg lesion as shown in the image, and on examination lesions are painful and edges are well demarcated and raised. He also complains of blisters over his body. He is otherwise normal, does not have any other disease. What is this? Before telling me the organism, tell me what is this condition? The answer is okay, so I'm getting answers from previous questions also. Yes, this is erysipelas. Erysipelas is a sorry. This is erysipelas, and erysipelas is caused by group A beta hemolytic streptococcus. It is caused by group A beta hemolytic streptococcus. Why I call it erysipelas? Because I see an erythematous painful lesion which is well demarcated. The purpose of giving well demarcated is to differentiate erysipelas from cellulitis. Cellulitis is deeper. Erysipelas affects more superficial dermal lymphatics, and that is why it is very well demarcated. It presents with painful lesions, is usually seen in healthy individuals, and is caused by group A beta hemolytic streptococci. Right? So not group B, it is group A beta hemolytic streptococcus. Okay. This question was to help you differentiate between erysipelas and cellulitis and causative organism. Okay, because cellulitis is usually caused by staph. It can also be caused by H influenza type B. So in the question you should be able, because it is given well demarcated, know that erysipelas is more superficial, so is more well demarcated. So don't get confused, okay? A 40-year-old female comes with complaints of pain in her fingernail. On examination, nail folds are seen to be red and erythematous. What is the most likely diagnosis here? So when you see an inflamed nail fold which has pus in it, which is red, which is tender, which is painful, what is it called as? Absolutely right. It is called as paronychia. It is called as paronychia. Paronychia is nothing but inflammation of nail folds. So inflammation of nail folds, it can be chronic or acute. Acute will usually present with this picture, where I have inflammation, where I have pain, where I have redness, and where I have pus in it. Okay, and chronic paronychia on the other hand will present with more scaly, more dry appearance. Yellow nail syndrome is seen when the nails become yellow. It is painless condition seen with lymphedema. In psoriasis, we have already discussed that we see pitting and we see oil drop sign. In alopecia areata, again we see pitting. So this painful, tender nail folds is a feature of paronychia, and it is called as paronychia. Clear? Moving on to the next question. The girl seen in the image has had history of severe sunburns, freckling with just few minutes in the sun. What is the most likely diagnosis here? Yes, you all are right. Staph is the common cause for acute paronychia. The chronic one, you have to think of Candida. And yes, this is a patient of xeroderma pigmentosa. This is here, xeroderma pigmentosa is a DNA repair defect. It's a disorder of DNA repair defect, and because of that, the patient, when they go out in the sun, their DNA is damaged, but it cannot be repaired, and so all the manifestations happen. So they are very sensitive to sun. They will not open their eyes. They will have freckling. They will have telangiectasias. They will have sunburns, and they are very prone to malignancies, and they also have lot of ocular side effects. So xeroderma pigmentosa, dry skin which is pigmented. Bloom syndrome is also a type of DNA repair defect, but here I see erythema and telangiectasias. It is definitely not Watts or LE. Yes, there is nucleotide excision repair. The specific defect is in nucleotide excision repair. So answer here would be xeroderma pigmentosa, and it is a DNA repair defect. A 40-year-old male presents with given rash after he had taken NSAIDs for his knee pain. He reported that he develops the same rash in the same location 6 months ago when he took the same drug. Very, very, very obvious history. Same drug, same location, every time it happens. What is it called as? Yes, this is called as fixed drug eruption. Fixed drug eruption, as the name implies, there will be a drug involved and there will be a fixed location. So at the same area, after taking an NSAIDs are the most common cause. Patient develops erythematous lesions which eventually turn hyperpigmented, which is very, very classical. So you see well demarcated hyperpigmented lesions which can be single or multiple. Okay. So the answer here would be fixed drug eruption. NSAIDs is the common cause. Drug, same drug, same place. That's why fixed. Okay. The image shown below is pathognomic finding in psoriasis. What is it called? So even if you're not able to see the image, what is the pathognomic finding in nail psoriasis? Yes, it is the subungual or oil drop sign, in which what happens? There is a distal onycholysis, and on the proximal border of this distal onycholysis, you see an orangish to yellowish spot which is called as oil drop sign or salmon patch. Some people also call it as salmon patch. This is very, very characteristic of psoriasis and represents parakeratosis of the nail bed. So nail pitting is the most common feature of nail psoriasis, and the type of pitting that I see here is deep, random and irregular. I see alopecia areata also presenting with pits, but there the pits are more geometric, more symmetric. Here they are deep, random and irregular. Pterygium and thinning of nails are feature of lichen planus. We have already discussed that. But oil drop sign is a characteristic feature of psoriasis affecting the nail. What is the clinical sign shown in the image given below? Okay, I know this can be a bit confusing because I don't think so. The image is very well given. So let's see. What do you think? Yeah, so if this image is given, I will also mark Koebner's phenomena as the answer. Dermographism, remember, you will not see gaps like you see here. Okay, so this is how I will differentiate dermographism from Koebner's if I was given the exactly same image. Though I think you would be given more representative image, but even if this is given in this image, I'll mark Koebner's phenomena, because in Koebner's phenomena it is not necessary. So lesions are formed along the lines of trauma. In dermographism, you will get a full linear lesion, and there will be a wheel-like appearance. There will be some swelling, some redness along that, right? So dermographism, okay, I'll come back to that, Paris. Just let me finish this question. So dermographism is a type of physical urticaria, also called as writing on the skin. So you can actually write. So wherever you scratch, you develop linear wheels on that. Nikolsky sign is seen in pemphigus. This is Koebner's. We have already discussed. Auspitz sign in psoriasis. We have already discussed. So what I told you in last time was that last question was nail pitting is the most common feature in psoriasis, and the type of pitting that you see is deep, random and irregular. So something like this. In alopecia areata also you would see pitting, but there the pitting is like this. Very geometrical pattern. So this is alopecia areata and this is psoriasis. Okay? Yes, we already discussed that. Amazing. So that brings me to the end of the session. And these were the previous 5 years questions which have been given in the FMG exam. If there is any other question that you would like to ask me, please go ahead. I'll wait for a minute, wait for your questions and try to answer them. And all the best. Again, I'll repeat, read all the options, read the question carefully. Sometimes the question looks very obvious, but the examiner is trying to ask something else, and in a hurry we mark something else. So please make sure you read the questions and the options well. Try to mark the important points in the question so that when you're coming back to the question, you can quickly see that what are the relevant points there. Okay, and you know your subject very well. I saw it today. You knew everything. Just have your confidence during the exam day and do it pretty well. And also don't forget to like and subscribe this channel for regular updates. I agree, Pradeep, that it is controversial. Yes, it can also lead to embryopathy, but if you have to mark one, the most common defect that is associated with isotretinoin would be neural tube defect. Bloom's syndrome is also a DNA repair defect like xeroderma pigmentosa, but there the important features are patient presence with stunted growth, patient presence with early neoplasias, and you have erythema and telangiectasias on the malar area of the face. The characteristic faces that you see in Bloom syndrome is also called as Mickey Mouse faces. I don't think so. They'll be asking you Bloom syndrome, so you can forget about that. Okay, can you explain leukoplakia? Yes. So leukoplakia is a clinical term. Leukoplakia is a clinical term for any white patch which is asymptomatic, which is present in an individual where you have still not established an etiology. Okay, so leukoplakia has no etiology. It has no specific histopath feature. It is just a diagnostic, clinically diagnostic term which is given to any white patch which is painless, which is asymptomatic and present in the mouth in an individual. So when you see a leukoplakia patch, you have to think of all the DDs. So it's basically a diagnosis of exclusion. And then you go for a biopsy to rule out oral cancer. Okay. So Vendita, you're right. Favus is caused by Trichophytonch conleni. Is there a question there? Yes, Paris, I would say for now, please don't go into the details. Just go with rapid revision and go with previous year questions, and that should do the deal. And don't forget your smaller subjects because they are more scoring and very quick to revise. Right. Okay, so you want to ask how does Favus looks like? Okay, so Favus presents with cup-shaped crust. It presents with cup-shaped crust called as scutula on the scalp. It is a type of inflammatory tinea capitis. This crust is basically the colony of fungus, and this is typically caused by Trichophytonch conleni, and it shows positive Wood's lamp fluorescence, and it will heal with scarring. So oral cancer can have a lot of features, Swati. Oral cancer can present with ulcers, it can present with growth, and it is basically diagnosed on a biopsy where you see dysplastic cells. Okay. So no more questions. So I will end my session here. It was lovely. It's always lovely interacting with you. And do not forget to like and subscribe the channel. And all the very, very best for your exams. I'm very sure you'll do very well. Just don't lose your confidence. Be very confident and read your questions well. So signing off for now. Take care. All the best.